Hey everybody, and welcome back to another video here at Whiteboard Medicine. We appreciate you checking it out. Hopefully everybody's having a good day today. We're going to be talking about Acute Respiratory Distress Syndrome, ARDS, ARDS, basics. So this is going to be kind of a basic overview of this condition. We're going to start by just talking about what it is, what's it characterized by, how many people it affects, the mortality rate, both for mild, moderate to severe. We'll talk about causes, pulmonary versus non-pulmonary, the pathophysiology or how exactly it's happening, how to diagnose it, the Berlin criteria, chest x-ray findings, and how to manage it, particularly the multi-organ system management, because ARDS, even though it's a primary lung disease, does cause disease of other organs too. So with no further ado, we want to take a quick 30-second break for the introduction. Don't go anywhere. We'll be right back.
Hey everybody, and welcome to Whiteboard Medicine. We appreciate you checking out the video. Here at Whiteboard Medicine, our goal is to create medical education content for all types of interested learners. That includes videos, practice questions, study resources, and much more. We would love for you to join our community by subscribing, hit that bell button. We're also working to build a high-yield Patreon page. It's going to be full of practice questions, video outlines, notes, commercial-free content, and much more.
None of these videos are intended to be acted upon as medical advice. Please pause the video here and read this disclaimer in its entirety before moving on.
All right, thanks for sticking around. So Acute Respiratory Distress Syndrome, or ARDS. This is a life-threatening condition. Many patients who are critically ill that get this do die from it. We see it, unfortunately, quite frequently in the intensive care unit, particularly the medical intensive care unit, although you'll see it all over the place, the emergency department, medical, surgical, neuro, cardiac, all ICUs, patients who are critically ill are all at risk for this condition. It is acute in origin. This isn't kind of a chronic progressive disease. It comes on acutely, and it can stick around. We're going to talk about kind of the chronic fibrosing phase of this disease, but when it's the onset of it is acute. It's characterized by hypoxemia, low oxygen levels in the blood, and actually high CO2 levels often as well, or hypercapnia. There are usually bilateral lung infiltrates, and this is not pulmonary edema from a heart cause. So it's not cardiogenic pulmonary edema. And if this is all confusing, trust us, we are going to dive into all these things and explain it. It affects, in the USA alone, almost 200,000 people per year. So we wouldn't go as far as saying this is a common disease, but you do see it. It does happen, and we see it every single week when we're rounding. So it is something that does happen, something that those that work in healthcare will come across and need to know how to diagnose it, manage it, and something that unfortunately people may have a friend or a family member who has had it. The mortality rate is quite high. It has gotten better over the last decade, but it still is around 25 to 45%. And most of that difference is depending on if you have mild disease. We'll talk about what that means. That mortality rate's 25%, moderate disease, 32%, and severe disease, 45% mortality. So those that get the disease and unfortunately die from it, 25 to 45% of people, so it's quite mortal. Those that don't die, there is a significant degree of morbidity. So patients often, if they have it and do not succumb to the illness, will have some degree of permanent organ dysfunction, whether that's kidney dysfunction, liver dysfunction, neuro dysfunction, heart dysfunction. So those that don't succumb to the illness do have a fair degree of morbidity that they have to kind of deal with and work on treating and recovering over time. All right, what are the causes? We want to start with the causes of ARDS. Well, interestingly enough, even though this is a disease of the lungs, there are both pulmonary causes, which you would expect because it's the disease of the lungs, but there's also non-pulmonary causes or extra pulmonary causes. Starting with the causes that are pulmonary, classical things that people get: pneumonia, right? An infection of the lungs. This could be viral. This could be bacterial. We've seen fungal ARDS from blastomycosis, right? We have not personally seen a parasitic infection in the lungs causing ARDS, but it probably can. But we've seen ARDS from viral causes. We've seen it from influenza. We've seen it from CMV. We've seen it from many bacterial causes of pneumonia. We've seen it from fungal. Aspiration, right? Aspiration is when you unfortunately inhale stomach contents into your lungs, and it usually causes what we call a pneumonitis. All right, pneumo being lungs, itis being inflammation. That can cause ARDS. Ventilator induced. If you have to go on mechanical ventilation or a ventilator, unfortunately, that ventilator can sometimes cause ARDS. That is not to say that you don't need the ventilator or that you would be better off without the ventilator, right? Ventilators are not a fix or a cure for anything. They simply are the last ditch resort to buy time to try and let your body heal from whatever illness is causing you to go on the ventilator. But those ventilators can cause a degree of lung damage, especially if you don't keep a close eye on things. E-cigarettes, vaping, has been shown to cause ARDS. Now, there's some controversy here. There's a condition called E-valley. E-cigarette and vaping associated lung injury, which is kind of on the spectrum with ARDS, but that is something that's often quoted. E-cigarettes. Smoke inhalation can cause ARDS, and near drowning, those that unfortunately aspirate water into their lungs, that's a cause of ARDS. Non-pulmonary causes, so blood transfusions, very uncommon, but can happen. Drug toxicity, both from prescription drugs as well as those that abuse substances. Pancreatitis. Pancreas is an organ in the abdomen, and pancreatitis is, when the pancreas is itis, inflamed. This can be caused from gallstones, alcohol, odd things like scorpion stings, trauma, all sorts of stuff can cause pancreatitis, but this can cause ARDS. Sepsis, so really any infection, right? An infection in the urine. We already talked about pneumonia, an infection in the lung. Bacteremia, or a blood infection, right? An abdominal infection. Skin, really bad skin or soft tissue infection, STI, soft tissue infection, not to be confused with, we'll say, an STI. Fat embolism, this is where you break one of your long bones and some fat from the bone marrow gets into the blood, and that can cause ARDS. And trauma. Trauma to the lungs and severe multi-system trauma otherwise. So what you're probably starting to pick up on is that this is a systemic disease that does, to a higher degree, affect the lungs, but it's birthed in the whole body, right? And you'll start to see when we talk about it more that it's really a multi-system disease, even if the most severe injury is often to the lungs, right? This is when a systemic process kind of disproportionately starts to affect the lungs, which is why all these non-pulmonary causes can cause ARDS as well. All right, on to the next, pathophysiology. So this is we're gonna go into a whole kind of series on ARDS, looking at a whole bunch of more advanced things, and pathophysiology is going to be one of those. So if this is going to be a brief overview of pathophysiology, if you really want to dive into the nitty-gritty, definitely check out that future video. We're going to have a whole playlist on ARDS linked in the video description. But when we talk about the pathophysiology of ARDS, we usually think about it in terms of phases. Okay, so there's phases or stages. The first one is called the exudative phase. The second is called the proliferative phase, when some healing starts to happen. And the third is called the fibrotic phase. We're going to get into each one of these, starting with the exudative phase over on the far right. For those of you not familiar with these drawings, this is obviously lungs, right? If you were to kind of zoom way in on a small part of this lung, you would find something like this. Right, these are alveoli. They're kind of the air sacs where gas exchange happens, all these kind of balloon structures. And they come off of the small airways, bronchioles. And these are the tiniest of windpipes. So, the trachea here is the biggest windpipe, goes into the main bronchi and branches off into the smaller and smaller bronchioles and airways. And these then connect to all the alveoli, and this is where gas exchange happens, right? And the reason gas exchange happens here is because these alveoli are really thin-walled, and they're covered with all these arteries and veins. So if we were to just take one of these alveoli and we were to zoom way in, you would see this. This is an alveolus, a single alveoli. And the thing to take from here, right, is this is not water. This is where oxygen is breathed in, right? And it fills this area. And then this is a really small capillary, a blood vessel that is coating the outside of the alveolus. And what happens is CO2 from inside this blood vessel diffuses into the alveolus, and then oxygen that we breathed in diffuses into the capillary, right? And that's how we exhale carbon dioxide, inhale oxygen, and that oxygen is obviously what goes into the bloodstream and feeds our organs. So what happens in the exudative phase of ARDS, this is within the first 7 days, and we'll talk more about this 7-day timeline when we get into the diagnostic section. But remember, this is an acute disease. So this is within the first 7 days of kind of one of these inciting acute events, right? Let's say you got pancreatitis, or let's say you got bad pneumonia, or goodness forbid, you had a near drowning event. Within 7 days of one of these acute events, you start to get changes in your alveoli. And what happens is you get damage to the endothelium, right? The endothelium is the thin layer of cells that coat a capillary, coat a blood vessel. And you start to get damage to the epithelium. The epithelium is the thin layer of cells that coat the alveoli. And the only thing separating the endothelium from the epithelium is this we call it the thin basement membrane, BM, basement membrane. So you get recruitment of inflammatory cells, right? There's some kind of systemic inflammation or inflammation in the lung that leads to more inflammatory cells. And those inflammatory cells get to the lungs and they start to cause damage. They start to break down the endothelium and they start to break down the epithelium. And obviously the capillary is full of blood and plasma. And this is a really thin wall, essentially balloon filled with air. So when you start to get damage, these gaps start to form and lead to fluid traveling from the capillary plasma into the alveolus itself. And you start to get this proteinaceous fluid accumulation within the alveolus because there's that increased permeability between the capillary and the alveolus because you get damage to the endothelium of the capillary and the epithelium of the alveolus, driven by inflammatory cells. And then this balloon starts kind of filling with proteinaceous fluid. You lose surfactant. Surfactant is this lubricant that coats the alveoli. It doesn't develop until you're often more than kind of 20, 25 weeks as a fetus, and as such, when fetuses are born too early, they often can't survive because they don't have surfactant to keep their lungs inflated. So you start to lose this surfactant because it's mixing with all this proteinaceous plasma fluid accumulation, and then these alveoli start to collapse down, right? The inflammatory cells start to damage the type 1 and type 2 pneumocytes that are kind of coating this alveolus and are responsible for repairing things or getting rid of that proteinaceous material. So not only are these junctions forming, but the cells that are supposed to remove some of this proteinaceous material start to get damaged. Okay, you lose the surfactant, and the summary, what happens is that the alveoli start to collapse, right? Instead of being this nice balloon, they kind of start to shrivel down, filled with this proteinaceous material that doesn't allow any gas exchange, right? So this blood vessel is still carrying capillary blood with full of carbon dioxide, but that carbon dioxide can't get into the alveolus and then breathed out. So you get a buildup in carbon dioxide in the blood. In addition to that, there's still oxygen that you're breathing in through your windpipe into your bronchi down to your small bronchioles, right? But when it gets to the alveoli, these alveoli are all collapsed down. So this oxygen can't get into the blood because it can't get to the alveolus. And as such, you're going to have low oxygen in the blood, hypoxemia and hypercapnia. Okay? That is the exudative phase. In addition to that, and we'll go more into this in the advanced pathophysiology section, but as all these start to collapse down, you get things, we're going to just say these words, and if you're interested, check out our ARDS playlist because we're going to go more into it, but you get VQ mismatching, you get increased shunting, increased dead space, decreased lung compliance oftentimes, and all that are kind of results of the collapsing down of these alveoli from the damage to the endothelial and epithelial cells and the leak of proteinaceous plasma into the alveolus itself. So if you survive this process, you can sometimes transition into the proliferative phase. This is kind of 7 to 14 days, okay? And this is somewhat of a healing phase. So what happens is your body finally starts to kind of wake up, okay? And it starts to say, gosh, I have all these immune cells kind of all within my alveoli. I have all this damage. I need to start clearing that out. So what happens is there starts to be kind of apoptosis and clearance of all the neutrophils that are filling this area. You start to get some repair of those type 1 and type 2 pneumocytes to clear out a bunch of that proteinaceous surfactant, right, to start clearing this out. You get lymphatic drainage. Your lymph system is where your immune systems travel, and there's a lymph system in the lungs too. And that lymph system starts to drain out a lot of that proteinaceous material filling the alveoli. And you also get increased fibroblasts. These are repair cells, and these start to enter the lungs and start to repair some of the damaged tissue. If this goes well, you can have a degree of recovery, right? These are the patients that end up surviving. One of the challenges, though, is if there's a lot of damage done or if this fibroblastic response is too robust, you'll actually transition. So we said you go from exudative to proliferative. You can actually transition from proliferative to fibrotic. And the fibrotic phase is when your lungs start to get all stiff, right? Because you had so much fibroblasts and they proliferated so much that they laid down all this kind of firm fibrin, right? Scar tissue. And that doesn't allow the lungs to expand as robustly, right? And that is if you have so much of this proteinaceous material in the alveoli and you can't clear it all out, that it starts to kind of get walled off. These fibroblasts start to proliferate more, and you enter this fibrotic phase. Not everyone progresses to this, but this is a chronic phase that you unfortunately have to live with, and it can cause a severe, significant amount of kind of chronic lung disease over time. All right, so that was the pathophysiology. All of these things lead to, as we talked about, hypoxemia, tachycardia, and then we'll talk more about this, but you can get multi-organ failure and death. Because this, as we set up here, this is a systemic process. And as such, low oxygen levels, high carbon dioxide levels, sometimes this can lead to a degree of acidemia as you can't clear your carbon dioxide out. Lung injury. The lung injury then leads to more inflammation in the body. And all of that can lead to multi-organ failure or injury. So this is a multi-organ system problem. All right, how do we diagnose? We talked about what causes it, but how do we diagnose it? Well, for this, we often fall to a criteria known as the Berlin criteria. And what the Berlin criteria are a set of criteria that, if you have them, may imply a diagnosis of ARDS, but it's imperfect, right? The criteria are, though, new or worsening symptoms within 7 days of an acute event. And remember that acute event are the things we talked about. Things like pneumonia, things like pancreatitis, right? Burns, I don't think we put that on the list, but burns can do it. Things like aspiration, right? All these are kind of that acute event. So if you're sick from one of these acute events, you have to be within 7 days. In addition to that, you have to have bilateral opacities on imaging of the chest. What does that mean? Well, this is a chest x-ray here, okay? And you can see that these are the two lungs. One lung, two lungs. This is the heart here, all right? This is the vertebral column. Obviously, these are all ribs, clavicle, diaphragm. And this area in here is what normal lungs look like, okay? But lungs in ARDS have these bilateral opacities. So you get some muck built up in here, and it'll look more white on each side, often patchy, usually worse at the bases. All right, so you kind of get these bilateral opacities in both lungs. It could be a CAT scan of the chest x-ray, what have you. And then your PaO2 to FiO2 ratio is less than 300. What does that mean? Well, the PaO2 is the arterial dissolved oxygen content. So this is often arterial blood gas or a blood sample from the artery. And that's the amount of dissolved oxygen in the blood, in the arterial blood. The FiO2 is the fraction of inspired oxygen. This is the amount of supplemental oxygen you're giving, right? So FiO2, just at atmosphere, at sea level, just in the normal atmosphere is 21%. But if you're sick, we can give you extra oxygen, right? We can give you a nasal cannula oxygen. We can give you a high flow nasal cannula, right? You can get BiPAP. You can get an intubation, mechanical ventilation, and I can control how much FiO2 you're getting. So it goes 21% to 100%, obviously being the most. And then you divide the PaO2 divided by the amount of extra oxygen I'm giving the patient. And if that is less than 300, that then is consistent with ARDS. So you have to be within 7 days of an acute event, you have to have bilateral opacities on imaging of the chest, and you have to have a P to F ratio of less than 300. The one caveat to this, which is really important, is that this cannot be secondary to a cardiogenic pathology. So you can't just have fluid overload. Fluid overload can cause bilateral opacities, pulmonary edema. So you have to be quote unquote dry. It cannot solely be secondary to a cardiogenic pathology. All right, now we've diagnosed it. We know how it happens. How do we manage it? Well, for management, we broke it down into a couple different things. Because remember, we said ARDS affects multiple different organs. A big one of those organs is the heart. If we draw the heart, ooh, we're not the best drawers. Let's see, that's going to be a heart. This is going to be the right ventricle, right atrium, left ventricle, left atrium. Right, the right side of the heart pumps blood to the lungs. All right, that's going to be our pair of lungs. Whereas the left side of the heart pumps blood to the rest of the body. That's a human's body. But what happens when we get ARDS? We mentioned you get all this damage to the lungs, right? All this proteinaceous material filling up the alveoli, alveolar collapse, diffuse alveolar damage. You can even get a fibrotic phase where you start to get scar tissue building up where you can't fully expand the lungs. And all that causes the right heart to start to have a large amount of stress, a large amount of increased effort to pump blood because blood vessels are all throughout the lungs, right? If we go up, you have all these blood vessels, right? That's what all these are on the lungs. And if all this is injured, damaged, inflamed, these blood vessels are going to be injured and inflamed too. And that's going to cause increased pulmonary vascular resistance, increased resistance to pump blood to the lungs. And that stresses out the right side of the heart. It can lead to right ventricular dysfunction or right heart failure because that pulmonary vascular resistance goes up so much. PVR, it's called. All right. So you got to keep a close eye on the right heart. You can do this through bedside ultrasound or formal transthoracic echocardiogram. This is bedside ultrasound. And it's really important to keep an eye on this. Sometimes people say you can do a central venous pressure, CVP, off a central line in the internal jugular subclavian. We've talked about CVPs a bunch of times on the channel. Check out our critical care medicine playlist. Again, it'll be linked in this video description. But keep an eye on that right heart. It's really important. You also get multi-organ failure. There's a correlation with ARDS and acute kidney injury. And why exactly this happens is tough to say. Most people think it's from kind of acute tubular necrosis, right? The tubules of the kidney start to get damaged and necrosed just in the setting of kind of hypoxemia, hypercapnia, more like SIRS criteria, so it's kind of systemic inflammation, acidemia, all that does injure and damage the kidney. So you start to get acute kidney injury. So you got to really keep an eye on that creatinine and really try to optimize and protect the kidneys as much as you can. Avoid nephrotoxins, as able, trend of the renal indices, all that kind of stuff. And then the big party player, the lungs. Management of ARDS is very complex. We're going to do an advanced management video. So again, stay tuned. We'll put it in the ARDS playlist. But just kind of a highlights in this one. The management of ARDS we often think about in terms of severity. Okay. So we talked about the P to F ratio, right? The PaO2 to FiO2 ratio. And there's mild, moderate, and severe, right? The P to F ratio less than 300 is mild. Well, we should say 200 to 300. The P to F 100 to 200 is moderate. P to F of less than 100 is severe. In all these patients, in all of them, you want to do what we call a lung protective strategy. That means they're on the ventilator with the tidal volume less than 6 cc's per kg of ideal body weight. Ideal body weight is based on the height, right? Because the size of the lungs is not affected by how much body fat you have. So get their height, calculate their ideal body weight. You can just look up charts for that. And then you want their tidal volume to be less than 6 cc's per kg. This has been studied. You want their plateau pressure. We've talked about plateau pressures on the channel as well. Look at the pulmonology playlist. Just like we said, look at the critical care playlist. We'll link this in the video description. But you want their plateau pressure less than 30, okay? There's some fancy stuff like driving pressure, DP less than 15. We'll talk about this in the more advanced management lecture. But this is lung protective strategies. Low tidal volume, plateau pressure is less than 30, maybe driving pressure less than 15. This is the real important one here and here, okay? If they get severe, we start talking about proning. Proning is where you flip them onto their stomach, all right? You put them on their stomach for a certain number of hours each day, and this is thought to help VQ matching, ventilation perfusion matching. And if we were to explain this, and maybe we'll do a whole separate video on proning, let us know if you'd be interested in that. But a lot of times patients are lying supine, right? They're kind of lying in their bed. Oh gosh, we're going to try to draw a human. This is going to be way too hard. They're lying in their bed, right? And their lungs are here. Shoot. But they got two lungs, so there's kind of one there and then one behind it. And gravity exists in medicine just like it does everywhere else. So you sometimes get a predilection when you're lying on your back to kind of more damage in the bases and posterior lung fields. So then if I flip you onto your tummy, right? So now I'm going to go for it twice. If I flip you onto your tummy, and we still have our lungs, that doesn't even look like a human, but now you get the picture, right? That damage that was initially in the back is now up at the front. And that means gravity is going to have more blood flow to the healthy lung tissue, gives these areas a chance to start to recover, and helps blood flow get to the areas of the lungs that have the least damage, right? It's helping that VQ matching. So proning in severe ARDS is something that does help improve mortality. You should do it. All right. And then protect against volume overloads. That's not to say make patients hypovolemic or dry them out, but this is critical in ensuring they don't get volume overloaded. That hurts their right heart, that hurts their lungs, that hurts their kidneys, right? Those are the three big things. Heart, oh boy, why did I start to want to draw a kidney? It's going to look like a lung. Kidneys and lungs. So just really protect against volume overload, really close volume assessments, usually at least twice per day, whether you choose to do that with ultrasound, clinical exam, invasive monitoring, what have you, but really protect against volume overload. So those are some of the basics of ARDS management. Again, we're going to do an advanced lecture on this, which will be in the ARDS playlist, linked in this video description. Hopefully this was helpful, interesting. Let us know what thoughts, comments, questions you have down below. Check out the page, check out the other videos, subscribe, hit the bell button, check the Patreon page out. We appreciate you all. And in any case, stay well, keep learning. We'll see you next time.